evening, everyone. On behalf of Merck India, I am Juhi Gupta from the Oncology Marketing team here, and it's a pleasure to welcome you all and for this discussion today, which is on evolving treatment landscape in advanced RCC. So today we are actually honored to have with us Professor Guillermo, right from Spain, whose global perspective will greatly enrich today's discussion, along with our esteemed panel of Indian experts. So we have a very exciting agenda ahead of us. However, before we begin and dive into the agenda, it is my honor to introduce our chairperson for today's session, Dr. Advani sir. All of us are know Dr. Advani, sir, so he needs no introduction. But to give you a brief about him, so he is one of India's most respected and pioneering cancer specialists with over 4 decades of experience in medical oncology. He currently serves as the Chief of Medical Oncology at Shushrut Hospital in Mumbai and is internationally recognized for his expertise in bone marrow transplantation, immunotherapy, targeted therapy, and also precision oncology. He has represented India at leading global oncology forums and has also been honored with prestigious awards, including the Padma Shri and the Padma Bhushan. With that, I would now like to invite Dr. Advani, sir, to set the stage for the session. Sir, over to you.
Yeah, good evening. Thank you, Jui, for giving this such a beautiful introduction. First of all, I would like to mention that we are very thankful to the Merck Oncology for giving us this opportunity to not only have the discussion on the RCC among us, but in the presence of a very esteemed international speaker, Professor Guama. And we are really lucky to have him. First of all, I would like to mention that the renal cell carcinoma, clear cell particularly, has undergone revolution, not only in terms of the treatment, but also in terms of the outcome. I still remember 40 years ago, we used to say renal cell carcinoma, we have no treatment. That was our discussion used to be with the patient. And today we have got multiple options, uh, ranging from the targeted therapy to the immunotherapy to double immunotherapy, and now even the CAR T cell therapy. So it's a real sort of a transformation that we have seen. And today we have gathered here to discuss and have an insight into all the aspects of the clear cell renal cell carcinoma. And I'm sure we will, in 1.5 hours, we will enrich our knowledge and information and the treatment recommendation from this webinar. And with these few words, I would like to now request Dr. Niti Raizada to give us the Indian scenario of the renal cell carcinoma. Dr. Niti.
Thanks so much, sir. Firstly, sincerely thank Merck for having invited me today. And it's a pleasure to be with such an esteemed faculty, Dr. Advani, and of course, our international faculty talking on renal cell carcinoma. I'll just give a brief of our understanding of the Indian scenario. Well, when we look at the Indian scenario, the incidence of kidney cancer is about 17,500 cases diagnosed each year, and it ranks amongst the sixth commonest cancers in India. When we look at the mortality, almost 10,500 cases die each year, which is a remarkably high number when you compare it with incidence, and of course, when we compare it with the global figure. There's a rising trend globally noted. And of course, India is also a part of this rising trend. And what I see, at least in quaternary care centers, is now we have more screen diagnosed cancers. There's no screening recommendation, but patients who actually come in the for health checkup and undergo an ultrasound sometimes are found to have asymptomatic kidney lesions, and often quite a few of them are early stage renal cell carcinoma. But in reality, this is just tip of the iceberg. There are almost 2/3 of the cases in our country which go undiagnosed. and only 33% of renal cell carcinomas are actually accounted for. And this is a number which is reflected only with the patients who are actually brought to our notice. What we also see that it is predominantly seen in men, which is numbers almost double as compared to females. We really don't know the number. And because of imaging improvement, well, there has been a trend towards increased renal cell carcinoma. When we look at the histological subset with Indian publication, we see that 75% of RCC in India are clear cell carcinoma, which is very similar to the global perspective. And this clear cell carcinoma variant is the one which expresses VHL, which is highly VEGF driven, and therefore the combination of VEGF, which we commonly use in our settings. And 10% of the clear cell carcinoma would have sarcomatoid features as well. 12%, that is the next common variant, is papillary type. And this papillary type could be type 1 or it could be type 2. Type 1 is MET associated and type 2 is FH mutations associated. Third common type is 8%, which is chromophobe and often seen with multiple chromosomal abnormalities. Now, when we sum up the risk factors, quite a few of them are actually modifiable risk factors and which are associated with other cancers as well. And these modifiable risk factors are tobacco and alcohol and excess BMI, body weight. And then, of course, there's occupational exposure, which is very unique to renal cell carcinoma. And one important chemical is trichloroethylene, which is often seen as an industrial solvent in automobile industry, aerospace industry, and of course, in chemical manufacturing as an additive. Now, there are certain non-modifiable factor. We know of age and of course, gender. But interestingly, height is also a risk factor where there's 5 to 10% increased risk with every 10 centimeter increase of height. Geography, of course, there are ethnicity connections and genetic variants noted. And of course, there's association with hypertension, diabetes, and chronic renal dysfunction as well. When we compare with global cohort, well, Indian cohort has a different IMDC risk grouping. When we look at the global perspective, intermediate category seems to be the highest category, about 58%. Next common is favorable and poor risk, which are about 20% each. But when we look at the Indian scenario, almost 38% fall in the high risk or the poor risk variant. Now, as far as treatment options are concerned, in terms of availability, we have everything which any country globally offers. But then, of course, we have barriers like access, awareness, late diagnosis, which is often the case, poor performance status when the patient comes. And of course, there are infrastructural issues in which certain, at least tier 2, tier 3 cities sometimes have a lack of awareness or lack of doctors. And then, of course, there are some compliance issues and follow-up issues. However, what is available to us are targeted therapies in the form of TKIs and mTOR inhibitors. We have IO combinations and all of them available, including IO plus TKI and IO, sequential therapies. And in a very small subset of advanced metastatic RCC, we also offer active surveillance as per guidelines. Mortality rate, in spite of all this, still remain high, and almost 60% mortality rate is noted. There is a rising incidence in India, as I just said. There is also a small rise of incidentally diagnosed RCC, which are known as incidentalloma. And then, of course, there's a higher proportion of poor risk subset. And when we look at the treatment landscape, it's a cluttered space with multiple treatment options. What we started a couple of decades back with only interferon and high-dose interleukin. Now we only talk about TKIs, mTORs, IO, small studies which focus on CAR T cell in solid tumors as well. And of course, the focus is on personalization. So with this, I hand over the session to Juhi for the next, to discuss our international speaker, please.
Thank you so much, ma'am, for the insightful session. We'll move on to the next part of the agenda. For this, I would like to invite Professor Dr. Guillermo. Sir has joined us from Madrid, Spain, and he's a distinguished medical oncologist specializing in the genitourinary cancer and melanoma. He is currently practicing at University 12th of October at Madrid itself, and he has over 300 publications and participation in the numerous clinical trials. His research emphasizes majorly in immunotherapy and targeted treatments in renal, bladder, and prostate cancer. So has played a pivotal role in ESMO clinical practice guide and also guidelines for RCC, contributing as a co-author in 2024 update. And he is also an active member of the multidisciplinary tumor boards and contributes internationally to the Oncology Guidelines Society. Professor Guillermo, we are very delighted to have you with us today. Over to you.
So first of all, thank you so much for the nice invitation. It's a real pleasure to be with you for two reasons. Obviously, the first one is because I love speaking about kidney cancer. And today we're going to be talking about kidney cancer. That although obviously when we are talking about patients and metastatic disease, we need to be very careful. But still, kidney cancer has been one of the most amazing solid tumors that we've seen, like are really advances in the last 2 decades. Please, next slide. So when we talk about kidney cancer, obviously everybody thinks about VHL. VHLs, it's associated with angiogenesis, and that's one of the key messages when we are talking about how we should be treating patients with metastatic RCC. We should not forget the angiogenesis plays a major role in most of patients with metastatic RCC. That's why we've seen an amazing development of different tyrosine kinase inhibitor, not only axitinib, sunitinib, pazopanib, but also the new ones such as cabozantinib or lenvatinib, and the new target also targeting the VHL axis, the belzutifan, the HIF2 alpha inhibitors, that recently we've seen that there are positive data coming with the combination of lenvatinib that will be presented in ASCO EU next month, but also the data with belzutifan in the adjuvant setting, proving that blocking the angiogenesis pathway, it's a key and relevant path that we should be doing in RCC in general. But obviously, all the data coming from the immunotherapy with PD-1 and PD-L1 therapy. Next slide, please. So when we look at the evolving field, I guess it's nice to see that now we've been using tyrosine kinase inhibitor over 2 decades. This is quite amazing. So 2016, that was sorafenib was approved. Now in 2026, we are seeing that from 2017, we've seen different combinations. And that's what we are usually using in metastatic RCC, either combination of IO-IO or IO tyrosine kinase inhibitor combinations. And now we need to talk about how we're going to access to all those drugs, what is the better options, and we need the most important thing that today in 2026, as physicians we can do, is we need to offer to our patients, we need to select which is the best option for our patients, because they used to live less than 1 year when the cytokine era, but now we know that they can live, the median overall survival is over 4 years. So it's really relevant. How can we pick? How can we choose the best treatment for our patients to get the best of all these treatments that we have available these days? Next slide. So when we talk about how can we choose from all different therapies that we have available in kidney cancer, because we have so many options. Obviously, we need to take into considerations patients and disease factor. In my opinion, this is usually the most important one. So it depends on the ECO, it depends on the comorbidities, it depends on prior nephrectomy, whether the patient has sarcomatoid features. All those things are extremely relevant when you are choosing your treatment. Obviously, this is happening in kidney cancer, but it's happening in every single solid tumor. But now we need to look at the efficacy and safety. That's something that was coming when we are using combination of drugs. In terms of efficacy, we need to think about the response rate, the CR rate. This is amazing. We did not talk about CR rate 10 years ago. Now it's a really important efficacy endpoint, but also the duration of response. Safety comes as really relevant when we are deciding between different options, but also something very relevant these days in 2026 is the available options, the dosing frequency, and more important, We used not think about it. Now it's one of the most relevant endpoints that we are seeing in every single phase 3 clinical trial. We want to improve the safety, we want to improve the efficacy, but we want to improve the quality of life, or at least maintain the quality of life of our patients. Next slide. So let's think about what happened with the Javelin Renal 101 phase 3 clinical trial with the longest follow-up that we have with trials with tyrosine kinase inhibitor and immunotherapy. So just to keep in mind, briefly, remember that was a study of more than 800 patients, randomized 1-to-1 to combination of Bavencio, avelumab, plus axitinib compared with sunitinib. The primary endpoint for this study was PFS, OS in patients with PD-L1 positive. The follow-up durations for IO tyrosine kinase inhibitor in the different studies, we have 49 months with clear, 55 with checkmate 9ER, 67 with Keynote 427, with the Javelin, more than 70 months of median follow-up for this study. So the results are going to be quite solid when we look at, because we have such a long follow-up for patients. Next slide. So why it's important when we are thinking about using different combination of drugs? So today, I guess we are using, and we are seeing as medical oncologists, we treat patients with kidney cancer, with many other diseases. Sometimes we don't think deeply all the treatments that we are using and all the potential that may develop our treatments. So axitinib, which is very known drug, we know that it's blocking the vascular endothelial growth factor 1, 2, and 3, which are the most important implicated in angiogenesis, but also in lymphogenesis, tumor growth, and cancer progression. So that's going to be something really relevant when you are using axitinib plus Bavencio. But also, one of the important things about the PD-L1 therapy is that when you are using Bavencio, you know that you are blocking PD-L1. But we have learned as well that we are able to release suppression of T cells mediated. And that's one of the most important issues that we see in kidney cancer. It's myelosuppression that is blocking the microenvironment and is not allowing to our immune system to respond. But also, in the combination of Bavencio with axitinib, we know that Bavencio is not only blocking PD-L1 therapy, but it's not only blocking PD-L1, but it's also is able to induce NK cell-mediated directed tumor lysis through ADCC. And this is really important because indeed these days are a lot of CAR T cells targeting NK cells, because that's one of the ways to really enhance our immune systems against solid tumors. Next slide. So this is quite solid results. I know you are all aware of these data. Bavencio plus axitinib improved PFS, 34 risk reductions, almost double response rate compared with sunitinib, 32 with sunitinib, 60% of the patients, median PFS, 14 months. That's amazing. So really solid results. We all know this data. Next slide. And with the longest follow-up, 73 months in the IO tyrosine kinase inhibitor. Also, Bavencio plus axitinib showed higher median overall survival, and the curves continue to separate till the end. This is quite relevant because we don't have here the other median overall survival from different IO tyrosine kinase inhibitor combinations, but we don't really know why. But in the other studies, even with the shorter follow-up, those curves come together. However, in the combination of axitinib plus avelumab, these curves, as you can see, they maintain separate. And the median OS with sunitinib was 38 months. Now we are talking about 45 months of median overall survival. So it's a longer follow-up period, means final results will be better, reflects the effect of later line treatments. And also it has been observed for all phase 3 IO tyrosine kinase inhibitor study. So that's why it's important to think that this study, these curves remain separated. Next slide. So a high proportion of patients in sunitinib are received subsequent line. This is also important. So when you look at the different treatments, patients with sunitinib, 70% of the patients receive a second line. However, with Axiavelu, only 60% of the patients. This is also something important when you're looking at what happened at the following lines. And when you look at in the favorable risk after Axiavelu, 39% receive subsequent line, 75 with after sunitinib received. So that all those patients were mostly treated at second line after the sunitinib as compared with the axiabelumab. Next slide. So now what it's getting important. So we learned this phase 3 clinical trial, Axiavelo, the Javelin 101, amazing study, positive study, specifically for the primary endpoint PFS. But now is that what's happening in the real world? So all these real world studies are getting especially relevant because they are proving what's happening in a routine clinical practice. Obviously, when you are talking about those 400 patients treated with Axiavelo in the clinical trial are really relevant. But now what's happening in all those countries using Axiavelo? Look at UK, response rate 62%. Look at in US, 42%. In Japan, 32. In Japan, DART, 49, 53. Basically, what we can say is like the median PFS, it's about what happened in the clinical trial, 13.5 months. But for example, we've seen even median PFS of 17 months, which is amazing, and has a ratio for OS of 0.4, which means that in the real world, I don't know it's going to be exactly replicating the data from the clinical trial, but even including patients that usually have worse performance status, more comorbidities, in the real world, Axiavelo performed really well in all these studies of real world evidence. Next slide. So avelumab plus axitinib has a well-characterized safety and tolerability profile. So you all know what's the data with axitinib, you all know what's the data with avelumab, you know how well is tolerated these combinations. But I think it's something really relevant that even in the phase 3 clinical trial, patients were double, so they were 2 times more on treatment with Axiavelo as compared with sunitinib. The patients leading to discontinuation were, or that was lower when you were using the combination as compared with sunitinib. Next slide. So all treatment-related adverse events, you know that the most frequent one will be diarrhea, but even though if you compare both treatments and the treatment-related adverse events, most adverse events were similar, diarrhea, hypertension, fatigue, as compared with just single tyrosine kinase inhibitor. But even though some side effects such as anemia, thrombocytopenia, neutropenia were more common in those patients treated with tyrosine kinase inhibitor with the sunitinib monotherapy as compared with those patients treated with axitinib plus avelumab. But overall, what you could say is like there were not major new adverse events using a combination as compared with one tyrosine kinase inhibitor such as sunitinib. Next slide. So this is important. So that's where we are today, 2026. So now think about all the options that we have available for patients with metastatic RCC. When I'm teaching to my the trainees, sometimes I'm coming to them and say, you know, metastatic RCC is really different from the other tumors because usually when you have a solid tumor with metastasis, you don't think about active surveillance. But when you have a patient with metastatic RCC, you can choose from active surveillance to use a combination of two drugs, which means that it's going to be much more difficult. Somebody's talking to me?
No, Professor, please
Ah,
continue.
okay, sorry. Apologies. I got confused. Okay, so what I was saying is like when you have a patient with advanced RCC in your clinic, it's going to be very difficult because you have, first of all, the options to use a combination of IO plus tyrosine kinase inhibitor, 4 different combinations, Axiavelo, Cavonivo, Axipembro, Lempem. All of them are pretty good. You have also double immune checkpoint blockade, Ipinivo. You can use also tyrosine kinase inhibitor monotherapy or even active surveillance. I'm going to say something. All of them are pretty good options. One day, the AI will replace us. But by the time being, we are here today as physicians to try to pick which is the best options, which is the best and the only options that we can start for our patients. And that's going to be very relevant. And that's why we're here today, all of us, to try to improve, to try to learn, and to try to be critical about all the data that we have to try to select the best combination or the best treatment for each of our patients. Next slide, please. So look at the phase line IO combinations trial. So when you look at median overall survival, which is pretty clear, is that when you are using a combination, that's going to be the main message. Using a combination, you are improving OS for most of your patients. So look at the follow-up, look at the median overall survival. Anytime that you are using a combo, the median overall survival in general, it's better compared when you're using a tyrosine kinase inhibitor monotherapy. The response rate is changing. When you're using the checkmate 214 ipi-nivo, 39%. When you are using combinations such as Axiavelu, 60%, Cavo-nivo, 55%. So we are ranging from 50 to 60, except when you are using ipi-nivo, response rate 40%. Next slide. Very important. What's happening when you are looking at all those data together? When overall survival curves are overlapping with iotyrosine kinase inhibitor, I try to need to approach because look at all this data. You get sunitinib definitely is worse, but when you're putting this data, it seems that even Axiavelu, it's one of the best combinations when you are comparing all these curves in as an statistical model. Obviously, you cannot specifically compare, you cannot say this one is better or not, but looking at the data with Axiavelu, it's surprising that is one of the best data ever reported in metastatic renal cell carcinoma. When you need to think this is just by chance, I mean, this is because the combination of one drug, tyrosine kinase inhibitor, axitinib, and the other one, the avelumab, that we know that have specific and very good things. Next slide. So when you are choosing for first line, we are thinking several things. We talk about the dosing, the site of disease, where the patient has liver metastases, that we know that that's poor prognosis, or compare when the patient has just thyroid lesions or pancreatic lesions, that for patients with metastatic RCC, it's going to be a better prognosis. But when you think about quality of life, PFS, OS, what the guidelines are saying, what is the local guidelines, what is the international guidelines, what is the IMDC, what is the clinician experience with the drug, that's going to be quite relevant. So you don't have experience ever with one combination, don't start to use that combination unless there is a power reasons to do so and to continue doing that. What about treatment-related adverse event discontinuations? What about primary PD? And even more important these days, what is the patient choice? Have you explained to the patients all this data? So it's how is the knowledge about the patients so he can also be part of the decision and should be a sharing decision when there are different options in such as metastatic RCC. Next slide. So yeah, next slide, please. So most important message. In RCC, one size doesn't fit all. So you cannot treat every single patient with the same treatment. Even you have patients with favorable. You cannot treat all favorable patients. In the favorable risk, you need to choose between using IO tyrosine kinase inhibitor, tyrosine kinase inhibitor monotherapy. You need to choose sometimes active surveillance. Sometimes you need to go for SBRT and follow up. Sometimes SBRT plus combination. The same thing for poor risk. You cannot treat every single one with ipi-nivo. You need to choose some of them ipi-nivo, but some of them will go for a combination of IO tyrosine kinase inhibitor. And that's why here today trying to deep a little bit in all this data. Next slide. So let's think about the favorable prognosis. In my opinion, next slide, this is the most complicated one. Next. So why favorable is the most complicated one? So first of all, because all these patients are going to live more than 5 years. So median overall survival for patients with favorable, it's median 5 years. So in my opinion, the most important thing, the most important message for all these patients, our task is not harm these patients. Why? Because the median OS is 5 years. So you need to be very, very careful about selecting the right treatment for these patients. And it's going to be more difficult than compared with those that are doing really bad. Because these patients may do pretty well, even with active surveillance. That's why we need to think very carefully. But something that we saw Keynote 4 to 6 in the clear, they did not show an improvement in the median OS when you were looking at those subgroup analyses. Next slide. When you look at favorable INDC risk group shows benefit with iotyrosine kinase inhibitor compared with tyrosine kinase inhibitor in studies such as real-world data from UK. So in this study, 95% of the patients receive Axiavelu as the iotyrosine kinase inhibitor. But if you look at the data, iotyrosine kinase inhibitor in the real-world evidence compared with tyrosine kinase inhibitor, there is a 60% of reduction of risk of death. So median OS was not reached with the iotyrosine kinase inhibitor and 40 months in the tyrosine kinase inhibitor group. And also the PFS was positive. So obviously, because the phase 3 clinical trials were not statistically powered to see differences in all those subgroup analyses, it's important and relevant to have real world evidence that are filling those gaps that we need to see in our clinical practice. So now we have this data coming from UK. It's going to be very solid. And you see that this data coming from UK is proving that iotyrosine kinase inhibitor in the real world, it's better. And if you look at in those cases, 95% were treated with Axiavelu. Why they were selecting that combination? Probably about the safety data and plus the efficacy data. Next slide, please. Next. So let's look at the data with Axiavelu compared with the other tyrosine kinase inhibitor. When you look at the data with Axiavelu by subgroup analysis, offers the better median overall survival for hazard ratio in favorable INDC risk group compared with the other IO combinations. Look at the Keynote 4 to 6, hazard ratio 1.10. It's better with sunitinib. Segme 9ER 1.10. It's better with sunitinib. Lempem versus Cabo 0.94. Segme Ipinivo 0.82. Look at the data with the Javelin renal, hazard ratio 0.73. So here we have the best data with Axiavelu in that specific population of FEVERA. Obviously, this is subgroup analysis. It is, but still in that population, and now looking plus the data from real world data from UK is really proving that Axiavelu, it's a good combination for these patients with favorable risk. Next slide. Let's look at the other side of the spectrum. Let's look at the poor INDC risk group. Next slide. So honestly, these patients are the most complicated because we're going to fail. It's going to be very difficult. We can rescue these patients. And indeed, we were talking that median overall survival for patients with metastatic RCC, we are talking about 48 months. When you talk about patients with poor INDC risk group, we are talking about median overall survival about 20 months, 21 months with Axiavelu compared with 11 months with sunitinib. So still the PFS will be lower, but look at the PFS. We are doubling the PFS with Axiavelu compared with sunitinib, and the hazard ratio 0.48. So why is this relevant? Because we know that for patients with intermediate and poor risk, we have also Ipi/Nivo. For patients with poor INDC, we have a very important decision to make because we can use IO, we can use Ipi/Nivo, but we know that patients with Ipi/Nivo, they have a chance they have the response rate is only 40% as compared with 60% with Axiavelu. But more important, there will be many patients progressing to Ipi/Nivo. And if you have a patient with poor risk and they progress, they are very unlikely to receive second-line therapy. That's why it's so important for these patients usually to select very carefully, because you may have probably just one bullet to use for your patient. Next slide. So let's look at again the first-line IO combinations trial in metastatic RCC based on the different endpoints. Something important. When you look at, for example, data with Javelin, with Axia Velu, the median overall survival for patients with favorable was 0.63. And when you look at for those patients with poor INDC risk, the hazard ratio was also 0.58. So we have now a combination, and that's why it's, because the things are moving so fast that honestly, as physicians, as investigators, we don't have time to really understand why some things may happen, why some results may be more important, what is the value of all those things. But when you look at really the data, you see that Axia Velu really outperformed in two specific populations. In those patients with favorable prognosis, where the hazard ratio was 0.73, but also for those patients with poor IMDC risk, where the hazard ratio was amazing, 0.58. So why is that? It's difficult to really understand, but the populations in Burris was quite representative, because 16% of the patients within the Javelin were poor risk, as compared with 9 in the Clear, 20 in the Checkmate 9ER, or 15 in the Keynote 4 to 6. So definitely data are really relevant. And also looking at the response rate in the favorable prognosis, 76%, the higher response rate in favorable, it comes with avelumab. So 3 out of 4 patients had response rate or objective response rate, which is something really remarkable. And also you see a double increase in the response rate when you are using Axiavelu in patients with poor prognosis. Next slide, please. So now we have, like, if you are looking treatment and you are thinking just in the IMDC criteria, you may think, okay, let's go for the favorable. You could go for active surveillance, you could go for SBRT, you could go for surgery in some cases, you can go for tyrosine kinase inhibitor monotherapy. But now we're reviewing that the data with Axia Velu, really the data looks pretty solid. So should not forget, when you are in front of your patients with favorable, that you should be thinking, okay, I'm going to treat these patients with systemic therapy, yes, no. But if you are treating that patients, probably tyrosine kinase inhibitor monotherapy may work for some patients, but for some patients, you may need to go for something that has proven to increase the OS, and where Axiavelo has really strong data. In the intermediate data, you have all those combinations, but also looking at the poor prognosis, looking at that specific data, the best hazard ratio proved in a phase 3 clinical trial comes from the data from the Javelin Renal 101 with the combination of Axiavelu. So you should not forget to have in your heads when you are choosing which treatment you should be using for patients with metastatic renal cell carcinoma. Next slide. So what is your preferred tyrosine kinase inhibitor? This is also important. So I was talking sorafenib 20 years ago. It was approved for using in kidney cancer. No one is using sorafenib anymore. Why? More toxicity. It's not as effective as all these new drugs that we have. So now we have different drugs. So the question is why axitinib has been used in so many trials as companion drug. Let's think a little bit about axitinib. Next slide. So one of the important things is the short life of axitinib. And why is important short life? Because all these drugs may cause adverse events, and especially when you are using combination of IO plus tyrosine kinase inhibitor, the plasma half-life is really relevant. And the good thing about axitinib, and that's the reason why is the only drug that you need to give twice a day, is because due to the short life, the plasma concentration rapidly decreases following treatment interruptions. But that's really good because we know that our drugs may cause many adverse events. And the good thing about axitinib is, like, if you are taking your axitinib and you stop taking the axitinib, the adverse event may resolve pretty fast because axitinib will disappear quite fast and the plasma concentration will drop dramatically. That's going to be very relevant because if you have your diarrhea and you don't know whether it is being caused by axi or the avelu, you stop the treatment and you know that was the axitinib or not. And if you have a hypertension and you need to control, you need to adapt, you stop the axitinib and you may control quite fast. That's something very valuable these days, especially when you're using combination and you need to figure it out whether the treatment is being caused, the adverse event is caused by one drug or the other one, especially knowing that PD-1 and tyrosine kinase inhibitor may have overlapping toxicities. Next slide. So, as I was saying, IO plus tyrosine kinase inhibitor have overlapping toxicities. So, in case of diarrhea, fatigue, food syndrome, hepatitis, so all those things that you may have for both drugs, you stop the tyrosine kinase inhibitor, you recover very fast. That was caused by your tyrosine kinase inhibitor. If it remains, that could be the cause, probably is likely to the other drug, in this case, the avelumab. That also is something good because you have to prescribe every only 2 weeks. Next slide. So, how to choose between avelumab or pembrolizumab? Is there any good reason to do that? Obviously, the access is the most important one, but let's think about toxicity-wise. Next slide. So, when you compare the efficacy and safety, the reality is that you have similar median overall survival. You have a clear separation of the curve with avelumab. That's very important. When you look at the 4 to 6, at the end of the day, I was saying that those curves are coming together. However, when you look at axiavelu, those curves maintain a difference. That's something relevant. Also, median follow-up is longer with Bavencio plus axitinib. And still, when you look at the data with favorable patients, 32% of the patients were favorable in the keynote 4 to 6. So they have better populations as compared with only 23% in patients treated with Bavencio plus axitinib. So at the end of the day, you have to think that both drugs have proved to be positive, median OS. But looking at what's happening at the end of the curve, you may think why axiavelu maintain that different. Also, it's small numbers, but also relevant. Look at the pneumonitis rate. 3% with pembro plus axitinib, 0.63 with avelumab. And more important things. Something very relevant, especially for poor prognosis, the discontinuation rate. So you don't want your patients to have a discontinuation because it is toxic. You don't want to do that because if you discontinue the treatment, your patient may have progressive disease and may die. Look at the discontinuation rate. 4.8% with axiavelu, 7% with axipembro, and steroid use 14% with axiavelu, double 27 with axipembro. Next slide, please. So in RCC, patients are living longer. As I was saying, especially for those patients with favorable prognosis, they are living longer. So hence now, as I was saying at the beginning, we didn't used to look at the quality of life. Now these days, the quality of life, its primary endpoint when you are looking at every single pivotal trial. That's why you need to think about how important it's going to be not only the overall survival, but also the quality of life. Next slide. So all combinations have similar efficacy, but the safety profile, it's slightly different. So when you look at the grade 3 adverse events, so there is a checkmate 214, ipi-nivo, only 46%, but it's an important but here, all of them are immune-related adverse events, which is also something remarkable to think and to consider. But when you look at the IO tyrosine kinase inhibitor combinations, the treatment-related adverse events 3 or higher, 57% with axiavelu compared with the others. It's lower numbers, lower discontinuations, lower use of steroids, lower rate of pneumonitis. This is relevant. How important is this? But I mean, it's something at least to consider when you have different options and when you have all drugs available and you are thinking about your patients. So for some patients won't matter, but for some patients will be quite relevant to try to decrease the number of adverse events of the steroid use or even the pneumonitis rate. Next slide. So the corticoids is really relevant because if you think about what's happened, you know that using steroids is always associated with bad prognosis in general. So we don't want to use steroids unless it's completely necessary. But you know that if you have steroids, may reduce the immune checkpoint therapy effectiveness, may increase toxicity related with the steroids itself, may decrease the absorption of the tyrosine kinase inhibitor, may alter the dynamics of the tumor. And if you look at the numbers, with ipi/nivo, 35% of the patients require high-dose steroids as compared with only 15. And when you look at all those combinations, the combinations that had lower need of high-dose steroids was the combination of avelumab, only 15% of the patient. Next slide. So let's look at the specific groups of patients with RCC. And let's start with sarcomatoid. Please, next slide. So when you look at the sarcomatoid component, has been quite relevant, and we know that this is a predictive biomarker of response. In patients with sarcomatoid, there is also evidence that Axiavelu is positive, median PFS 7 months compared with 4 months, hazard ratio 0.57. Said that, we need to acknowledge that the data with ipi/nivo in this specific population, it's also really, really solid. And I would recommend to use ipi/nivo for those patients that do really not require a response with sarcomatoid. But if you have a sarcomatoid component and the patient really require a response, in that case, I may be more inclined to use an iotyrosine kinase inhibitor. And in this case, we're seeing that Axiavelu also was much better than sunitinib in this context. Next slide. So there is also data that is really relevant. For many years, we know that we have many patients with one of the issues, indeed, when you are seeing patients with metastatic RCC is the kidney function. So most of our patients have some kind of decrease in the kidney function for many reasons. And now we're seeing here data from patients in end-stage renal disease, even in dialysis, and looking at the data, the frequency and the data that patients will need to use steroids. Here, there are data showing that even dialysis is not a contraindication to use Axiavelu because there are some patients being treated and without a special adverse event, and more important, all of them had partial response. Next slide. Avelumab is safer among other IO in RCC with lower risk of acute kidney injury. This is also a communication that has reviewed all the data. And when you look at all this data, obviously it's a review, but looking at the safety grade 3/5 with look at durvalumab 0.86 and avelumab 0.68 seems that it's better. And durvalumab plus low dose tremelimumab and avelumab were consistent among the top 3 safest treatments for grade 1/3 or 3/5 adverse events. And this is quite relevant when you are thinking that the safety comes really, really important treating our patients with metastatic RCC. Next slide. So first-line avelumab plus axitinib, it's also positive for patients older than 75. And this is also relevant because we're seeing more patients. But regardless the numbers, you look at the populations, you see all of them having response, 52 with Axiavelu, 27 in the overall populations. But looking at the data in older than 75 years old, when you're looking at patients with 75 years old, you see that response rate 42%, overall response rate 22 with sunitinib. So still you are seeing that your patients may do better regardless the age using a combination of avelumab. Next slide. Next slide. Yes, also, and that's important, looking at the data of pulmonary immune-related adverse events, we know that they are very very rare these adverse events. But looking at the data with avelumab, it's amazing because produce the least exacerbations of pulmonary immune-related adverse events. So again, proving here that the data with avelumab remains as one of the most solid in terms of the safety profile. Next slide. So for RCC patients, we need to strike a balance. Remember, we are thinking to try to choose the best for our patients. Obviously, it's not only about Axiavelu, it's about all the combinations that we have, all the treatments that we have, all the problems that our patients may have. And we need to always think a balance, an important balance between efficacy and safety. Next. So in summary, I think I don't know if I've been in quite long today, but in summary, what I want to just to remind you is like in RCC treatment, and I've been trying to basically try to push for this message, selecting the right therapy is crucial. We have many options. We know that there are patients with favorable risk group, and in this case, we have treatment with, we can do active surveillance for some patients. We could do tyrosine kinase inhibitor monotherapy. But now we need to acknowledge that the data has proven that Axiavelu shows better hazard ratio compared with other IO tyrosine kinase inhibitor. The same for IMDC poor risk. When you look at the IO tyrosine kinase inhibitor, Axiavelu showed 42% reduction in the risk of death. That's data from the sub-analysis, of course, but that's important. And safety. Safety is important because we want our patients to live longer with a better quality of life, and the safety comes with that quality of life. So it's critical due to long treatment duration, and despite the longest follow-up, Axiavelum has the lower discontinuations, the lowest rate of steroid use, and the better pulmonary safety. Obviously, with the subgroups, we know the better outcome with Axiavelum for patients even on acute kidney injury, elderly patients. We have data also for sarcoma recombinant. So definitely Axiavelu strikes as one of the combinations with better balance when you are thinking about efficacy and safety for patients with metastatic renal cell carcinoma. Thank you very much and happy to take any questions.
Thank you so much, Professor Guillermo, for the enriching talk on this topic, about treatment options in ARCC. And we'll probably park the questions for later and take it up in the panel discussion if that's okay to you.
Yeah, absolutely.
Thank you. So we move ahead with our agenda. And now that we've seen the data and theoretical part of it, now let's look at how AVI plus AXI behaves in a clinical setting. And for that, I would like to invite Dr. Alok Gupta, sir, who is a Senior Director and Head in Medical Oncology Department at Max Super Speciality Hospital, Lucknow. Sir, we are very delighted to have you. Forward to you on the session.
Thank you, Judy. Can you please share my slides? Yeah, thank you.
Yeah.
So at the outset, a very good evening to all, and thank you organizers for having me here and for this academic meeting. So it was lovely hearing the professor talk about the management of advanced renal cell carcinoma, and it was such a comprehensive talk, and it covered that in great detail as to what is the evidence and how do we practice. In continuation with this, I would be sharing some real world data, a study which was done in India, and followed by a case presentation to set the context for the panel discussion in the next talk. In this study, so it was a sort of a follow-up study where patients with advanced renal cell carcinoma were treated with this combination strategy of IO plus TKI. 54 patients were included. Across the spectrum, there were patients who were favorable risk, intermediate risk, and poor risk. The primary endpoint of this analysis was overall response rate, progression-free survival, and then also looking into various adverse effect profile and looking into the efficacy of this treatment as per the IMDC risk factors. The median age in this study was 57 years with a male preponderance, which is fairly understood. The time point, number of patients who received treatment beyond 9 months were 24, less than 9 months were 30, and the median duration of treatment was close to an year. There was a fair mix of metastatic sites. Around 66% patients had lung metastasis, 40% patients had bone metastasis, and lymph nodal metastasis. As far as the distribution of these patients was concerned, around 9% patients had favorable risk, 48% patients had intermediate risk disease, and 42% patients had poor risk disease, which essentially reflects our own clinical practice, day-to-day practice, somewhat we see in our clinics. Next slide, please. When we look at the best overall responses, we find that the disease control rate was 87% with the combination, and the overall response rate is around 61%. So which correlates fairly with the phase 3 clinical trial, which we just heard. So a response rate reaching close to 60%, even in our real life study. Next slide, please. The progression-free survival in our study was the median time point was close to what we have seen in the clinical trial as well. In fact, at 12 months, we find 54% patients were progression-free. The median was 13.2 months. As far as the overall survival is concerned, we are reaching beyond 3 years. 37.6 months is the median OS. And so almost everybody was alive at 12 months. 70% patients were alive at 24 months. So essentially, our real world analysis in terms of the response rates, in terms of PFS and OS, correlates with what we have seen in the clinical trial setting as well. Next slide. Now, amongst the better responding patients who indeed continued to receive the combination beyond 9 months, these endpoints are even better. The overall response rate in those patients went on to 79% with a near 100% disease control rate. Next slide. So we also look at how the IMDC risk assessment and how these patients fare in respect to the primary outcome measure, which was the progression-free survival. The 5 patients who had a favorable risk disease and a very good response rate, almost all of them responded. In those patients, the survival curve is much better. You can see the blue curve here, which is in excess of say 80%. In the intermediate and poor risk also, the majority of patients actually responded. The response rates in intermediate risk were 61%, and in poor risk it was around 52%. And in these patients, the curve, although slightly less than the favorable risk group, which is expected, but it is a fairly good survival curve in intermediate and poor risk, reaching somewhere around 12 to 13 months of median PFS. Next slide, please. Now, Professor also discussed certain specific patient populations. In this analysis, there were 2 patients who had sarcomatoid changes. One patient had achieved a partial response. The other patient achieved somewhat stable disease. So overall disease control rate was 100%, although the percentage would not be the best way of depicting that. But yeah, so it reflects the real life practice where we do come across patients who have sarcomatoid changes, and we have seen that and patients who have even as much as 50% sarcomatoid histology. These patients seem to be doing fairly well with this combination of avelumab axitinib. Next slide. So the summary from this clinical trial is it essentially tells us the real world effectiveness in Indian patients. Not a big study, but yeah, around 54 patients were included. And they looked into various outcome measures, including the response rate, which is around 61%, correlating well with the Javelin Renal 101 trial. The disease control rate, very excellent, around 87%. The median PFS and OS, again, correlating with the clinical trial, median PFS of 13.2 months and OS of 37.6 months. Even patients who had intermediate and poor risk IMDC, these patients also responded and achieved a fairly good median PFS and OS. Next slide, please. Yeah, so just a small case study to set the context. Next slide. So a 63-year-old lady, homemaker, no prior comorbidities and no history of smoking, evaluated for abdominal discomfort and detected with a renal mass in September 2021. Additionally, she had bone lesions. Next slide. Upfront presentation, she had hypercalcemia, which required treatment. She received calcitonin along with zoledronate and hydration. A PET CT scan done in 2021 at the time of diagnosis was suggestive of a soft tissue density lesion involving the left kidney. Along with that, there were multiple metastatic lesions in the lung and bony metastasis as well. A biopsy confirmed it to be a clear cell carcinoma. Next slide. So a final diagnosis of metastatic RCC was made along with lung and lymph nodal metastasis and bone metastasis. So risk stratification, it was IMDC high risk. Next slide. Then patient and family were counseled regarding the available options. The option of IU plus TKI combination was selected finally. Patient received combination of avelumab and exitinib. Next slide. So at first analysis, which was done in January 2022, after 6 doses of avelumab, there was a good response. Compared to the baseline PET CT, there was decrease in size and metabolic activity of the renal lesion and the bone metastasis as well. There were resolution of bilateral lung nodules. Next slide, please. So these are the scans at the time of diagnosis, October 2021, and then at first analysis in January 2022. You can see that the lung metastasis, they have resolved, and the bony lesions appear to be healing, and the renal lesion as well, it has decreased in size and avidity. Next slide. Now, the interesting aspect which Professor also discussed was the side effect profile and the quality of life, which we have generally found to be better with avelumab as compared to other IU agents in RCC. In this particular patient, the patient developed some skin side effects, including lichenoid eruption, which were grade 1 and managed with antihistaminics and topical steroids. Patient also developed grade 2 mucositis and asthenia, hypertension, which is expected with exitinib. It was noted but well managed. And then thyroid abnormalities, which are again very, very common with this combination strategy. So essentially, grade 1 to 2 adverse events, mostly well managed, not requiring at least not requiring treatment interruption. Some reduction in the dosage of avelumab was required because of hypertension. Next slide. So patient continued on the combination for a good almost 1.5 years. And in after 1.5 years, there were, so I'll be coming. So can we move on to the next slide? So after around 1.5 years into treatment, she developed neurological symptoms. She presented with recurrent episodes of headache. December 2022 MRI was suggestive of a brain lesion. Next slide. So since there was a sort of a solitary brain lesion with edema, anti-edema measures were instituted, case was discussed in tumor board, and it was decided that the patient can continue on same systemic treatment, but we need to treat with local therapy, either in the form of neurosurgery or SRS. Next slide. So patient ultimately end up receiving SRS, which is stereotactic radiosurgery, for that oligo progression in the brain along with anti-edema measures. Next slide. So this was the radiation dosing that what patient received, 27 gray in 3 fractions. And thereafter patient again continued for a good 6 months on the same combination. So after 6 months, patient developed new bone lesions, new brain lesions, and at that point in time, it was decided that it is wise to change the systemic treatment because it was not working anymore. So patient received cabozantinib for a few months, and then subsequently patient developed progression, and patient was not fit enough to receive any third line treatment, and therefore the treatment was stopped, and ultimately patient succumbed in November 2023. So around 26 months into treatment, around 2.5, close to between 2 and 2.5 years, which is what we have also seen in the clinical trials, at least for the high risk IMDC patients. Next slide. Yeah, so with this background and with this clinical study, I hand over back to Juhi, and thank you so much for giving me this opportunity. Thank you.
Thank you so much, Alok sir, for giving us insights and also your perspective into a real world setting. Thanks for that. Was really helpful for us to understand. Now, moving on with the most awaited part of the agenda, which is the panel discussion. And to moderate the panel discussion, I would like to invite moderator for the evening, Dr. MVC Chandrakant sir, who's an academic head in medical oncology at Narayana Group of Hospitals, Kolkata. Sir, we are delighted to have you today with us. Over to you.
Thank you, Juhi, for that introduction. And it was a wonderful talk. And Dr. Alok discussed the real world Indian scenario. So, in continuation to that, we will have a panel discussion covering important aspects of how to place a vaccine in our practice. Can I share the slides from my end?
Yes, sir.
Right. My slides are visible now.
Yeah, they are visible.
Sir, just one thing that Dr. Arnab is not there. He has not joined it. So
Fair,
the rest of other panelists are there. Yeah.
fair. Okay. Okay. So, IOTKI, close look in favorable and poor risk group. So I'll be asking all of you, and then I will be taking expert opinion from the professor. Right. So IOTKI close look. So these are the panelists that we have. I think this was a slide what professor just presented during his talk. More conservative or budget condition, or you have so many options of immunotherapy coming in the front line itself, either IOIO or IOTKI. Okay. So let me start with Dr. Alok. Dr. Alok, if you can take up this question. So do you select the treatment based on IMDC criteria? What are the factors that you would consider when you're treating?
IMDC is definitely something which we calculate in our day-to-day practice. Now, whether we modify our treatment based on somebody who's having intermediate or poor risk, I would say no, because since in the IO era, although we can debate that one combination is working better in favorable risk and the others are not. But having said that, in the IO era, uh, the difference of what we can achieve in the various IMDC risk groups has sort of blended. And essentially, we try and treat these patients with a combination strategy nevertheless. Although for patients who have a high risk disease, low volume disease, and with some form of sarcomatoid histology, we might be tilted towards using IO combination and not IO-TKI. But for others, especially those with large volume disease, symptomatic patients, and so on and so forth. So these are various factors which we take into consideration in selecting IO plus TKI. Most patients end up receiving a combination strategy. TKI alone would be reserved for patients who have contraindications to IO-based
Immunotherapy.
treatment. So that is how we select in our practice.
Right. Thanks, Dr. Alok. Uh, Professor Guillermo, can I request you? Like IMDC is one of the most objective criteria we use in our practice. Are there any other factors that we should consider before we select the regimen?
Yes, absolutely. So yeah, so IMDC, that's important. It's not it's a prognostic classification. So it's not predicting of response. That's something that we also should take into consideration when we are thinking about what is helping us to select. So IMDC is giving it's trying to understand how the prognosis of our patient is what's gonna happen. But when you talk about prognosis, you know that there are many other factors that we know that are really relevant in kidney cancer. So, for example, the location of metastasis. So everybody would acknowledge, would understand that it's not the same a patient with, although the patient is favorable. If you have a brain metastasis, you want to be more aggressive for that patient. So you want to treat that patient with active surveillance for sure with the patients with brain metastasis. So location of metastasis is going to be very relevant. And also, there are a couple of considerations that one, it's pretty clear that we need to understand its PDL1 and sarcomatoid. Sarcomatoid differentiation is a trigger to use immunotherapy. Usually, it's the trigger to use double immune checkpoint blockade, but if it's not double immune checkpoint blockade, you need to use a tyrosine kinase inhibitor plus immunotherapy. But you should not treat a patient with sarcomatoid differentiation without immunotherapy. That's something that's like a dogma these days. And the PDL1, although usually PDL1 expression has been very, very weak as biomarker, we should not forget that we are doing in Europe a phase 3 clinical trial, a huge study, more than 1,500 patients, led by Dr. Alvilles, when we are randomizing patients based on PD-L1 expression. So we are thinking that if the PD-L1 expression, those patients will do better with ipi/nivo. If the patients are PD-L1 negative, they will do better with tyrosine kinase inhibitor. That's still a hypothesis, but it's something that we are testing these days. That's why we should acknowledge as well. But if you want to go beyond IMDC, I will think about location of metastasis, and sarcomatoid differentiation as two key factors that we should not forget, regardless the IMDC criteria.
Excellent. I think so that very important. IMDC is one of the criteria. All other important soft criteria are equally important as IMDC, and that's how we would select our regimen. Great thought, sir. Thank you. Okay, so this is the IMDC criteria. It is quick. It will hardly take a minute to calculate, and I can easily classify them into favorable, intermediate, and poor risk. Right. Now let me go to Dr. Shantanu. Dr. Shantanu, this is a question for you. In your practice, if I ask you how many are good risk, intermediate, and poor risk, and among the intermediate, 1 to 2 criteria as favorable or intermediate. So you can take up both the questions.
Sir, honestly, favorable. I mean, I am yet to come across more than one or two patients of favorable risk, or genuinely favorable. Another way, anemia and I mean, anemia is one thing that we need to take that criteria with pinch of salt. I mean, in Indian setting, anemia is a tricky 11, 10.8 is almost always, I'll treat it as non-anemia. So such factors, but let us say other factors apart from anemia and probably WBC, anything related to WBC, I would be taking them as proper intermediates. Otherwise, I would label them as intermediate on paper, but I would be tending to guide them as likely favorable prognostically.
I think excellent points, Dr. Shantanu. I think, anemia can be like inherently be there unrelated to disease. That's very important. So, but anyways, we need to look anemia and then high platelet, high WBC in the context of the disease burden also. So it's in a context. It is not independent.
Right, sir.
But that's fair. So uh, we see a lot of intermediates as you said, and good risk curve not great in number unless that patient who is on follow up after surgery presents with a couple of small lesions, and that is a patient who is sort of active surveillance versus good risk, and that's the space, right? Well, Professor Guillermo, can I request you to take this question? Intermediate risk, is it all same, or can I take intermediate risk with one risk factor as a good risk? So what is your take on that? We have so you're muted, sir. I'm sorry, you're muted.
Sorry. So we've seen that there've been different studies about this topic, trying to look at those patients with intermediate. One risk factor is different to two. So it's pretty clear that the more risk factors, your prognosis is getting worse. So when you have 0, it's the better prognosis. When you have 1 is worse, 2 is worse, 3, 4, 5, 6. So you could do like a math. You could have more granularity in all those things. Like what we don't really know is how these really apply to how you select your treatment. In my opinion, based on this data, I don't treat. So what I would be very careful is about thinking that my patient has only one risk factor, and I want to treat this patient as favorable, and I'm gonna treat this patient just with active surveillance, for example. I wouldn't do that. So in my opinion, it's not changing that much having that different classifications. But definitely having one criteria is not the same as having two, is different. But I think there is an important step between 0 and 1 when you are taking the decision about what can you do with your patient. So if you have 0, so if your patient is really favorable prognosis, in the tyrosine kinase inhibitor era, those patients live really longer. So it's the kind of patients that you may think very careful what to do. Once you have 1 or 2, it doesn't really matter. You need to treat those patients with iotyrosine kinase inhibitor or double immune checkpoint blockade. But all those patients, you need to treat them. So it's not gonna change that much your management for that patient. That's my
right. No, that's perfect. That's how we minutely will read in between the lines. Not just IMDC. IMDC intermediate risk is also heterogeneous, and these are the IO TK combination therapies. These are the ASCO guidelines. I think we saw this during the presentation, and there we go. So one size doesn't fit all. You need to actually risk stratify and then treat. And let's quickly go to the favorable risk. So favorable risk, we saw all the IO-TKI trials. There is no difference in overall survival. In fact, the hazard ratios are crossing unity in some of the trials. Therefore, we need to be careful before we select. Right. So favorable risk, Dr. Anab. So Dr. Dubey, if I can request you to comment on this. So there is no difference in survival in terms of favorable risk if you put IO-TKI. So what do you usually use in this specific population?
So first of all, favorable risk patients are quite less in number. And if these patients, just not only these options, I would first consider that whether patient has high tumor burden, patient is symptomatic, is it rapidly progressive disease. So if patient is having limited tumor burden and not symptomatic, and the disease anywhere is not in the vicinity of vital structures, I'll give an option of active surveillance also. But if the patient is having systemic disease, rapidly progressive, extensive tumor burden, then surely IO plus TKI, the regimen which will be having higher response rate, I'll select. But yes, seeing the data of Almab plus Exitinib, that will be my first option which I'll be offering to my patients if they require systemic therapy in favorable risk.
Excellent. Very nice thoughts, Dr. Dubey. So, well, Professor Guillermo, if I can request you, so Ipi-Nivo favorable risk was not effective. Pembrolizumab, Nivo-Cabo, Pembrol-Lenva, all of them have not shown a favorable hazard ratio for favorable risk. Whereas why Avaxi is so unique biologically? Why this PDL1 inhibitor with AXI being the combination has shown a favorable hazard ratio for this favorable risk? What is so favorable and unique about this IOTK combination? So mutant.
As I was mentioning before, one of the things about using axitinib, one of the good things about axitinib is the half-life. So obviously we know how to handle different tyrosine kinase inhibitor, and that was a nice case that has been presented today, and the issues to use tyrosine kinase inhibitors such as cabozantinib that they may be eventually or more active, but it's associated with more toxicity. And that's something that we need to understand pretty well. And the good thing about using combinations, especially for this favorable, because when you are looking at favorable, there are still patients that could argue, I'm going to use tyrosine kinase inhibitor monotherapy because any single trial, a randomized phase 3 clinical trial has proven in this specific populations positive, but we don't have that data. And that's why you need to think that in favorable, you need to be more careful. And that's why axitinib is giving you that chance that if you stop treatment, the adverse event is going to resolve really fast. That's something important, especially with the diarrhea that is overlapping with the avelumab, or also with hepatitis or other adverse events.
Great thoughts. So not only the efficacy, but also the toxicity component is very important. That's what makes this Avaxi unique when compared to other combinations. Thank you, sir. So, Dr. Tanmay, if you can take this, is any IOTK combination like favorable risk if you are opting? So, which IOTK will you use? You feel IOTK is better than TKI alone in favorable risk? Yeah, Dr. Tanmay. You want to Dr. Tanmay? Okay, Dr. Alok, if you can take this up.
Yeah, so I mean, amongst all these studies, we find that only the combination of avelumab and exitinib, the combination appears to be doing better in terms of OS compared to the TKI alone. And therefore, that becomes an automatic choice. No other treatment combination appears to be doing better than TKI alone. So yeah, so it's a fair treatment option for patients who can afford definitely a combination strategy.
Right, Dr. Alok, if you can see the question on the screen, you agree for the statement?
Yeah, that's what
Monday
I said.
morning, Avaxi is the way to go, not TKI alone.
It's already it's already past several Mondays. It is the favorable option.
Thank you. Professor, what is your thought? Monday morning, Avaxi is the way to go for all favorable risks?
No. That was not my message. So never, it's always. I guess
Right,
I
okay.
was trying to explain that always is really it's really serious word in this
Right.
world. But definitely it's a combinations that if you have available, I think Axiavelo has proven that is one of the options that you really can go for patients with favorable on Monday or Tuesday, whenever you work.
Right. No, so usually we have conferences on Saturdays and Sundays, and therefore Monday morning is a way we spell it. Fair.
Okay.
So if you take the comparator as sunitinib alone, a TKI alone, if the comparator is, then Avaxi is a better bet for a favorable risk, and the data what we saw was the hazard ratio for overall survival in the randomized trial, and also the real world data that showed from the UK that showed excellent data. So these are some thoughts? If at all, if you want to give an IO TKI, Avaxi looks the most promising among all the existing regimens for the favorable risk. And this is the overall survival and progression-free survival. And this is the overall survival that you are seeing of Avaxi versus sunitinib. And this is the progression-free survival that you are seeing. Right. So, well, Professor, if I can request you, the Avaxi trial is basically a negative trial statistically, right? So that's the reason why Avaxi has sort of been not up to there in the mark. So you think this negativity is a statistical negativity, or is it a clinically meaningful regimen to use?
Well,
Clinically,
I
or
guess no, now that we have much more experience in all these trials, it's clearly that it's a positive, it's clinically meaningful, this data. Sometimes the questions, I would do the other questions, like, that the chances to have keynote 4 to 6 or the clear data or even the checkmate 90 are negative, if you reply the study, would be higher than 50%. So you may have the study negative, replying the study, although you do the same thing. So, sometimes when you need to look at, so we are very used to do very, very careful about the data and look at which is positive or negative. But look at the data, you see it's positive for PFS, it's positive for response rate, it's positive for one of the primary endpoints for the PD-L1 positive populations. We know that all those may be some bias, but at the end of the day, you're using axitinib, a tyrosine kinase inhibitor, very known, avelumab, a PD-L1 therapy that is being used like now for many other tumors. So that's why we need to be very careful about how we look at those statistically significant or not. So there are some studies that are statistically significant, but clinically are not meaningful. This combination is clinically meaningful, as you are seeing in every single step. So that's what something that we need to differentiate. But obviously, when it comes to different regulatory access and so on, when you have different combinations, that's why it's more difficult to basically to locate these combinations. But honestly, if you have only IO tyrosine kinase inhibitor, Axiavelu, or Ipi/Nivo, and that was the only study, everybody will be using Axiavelu for all those patients that require IO tyrosine kinase inhibitor.
excellent. So, just to extend, I can use avelumab axitinib for good risk. I can use for poor risk, but I'm not supposed to use for intermediate risk. Is that the message from this slide? Good risk, yes. Poor risk, yes, but not for intermediate risk. Professor Guillermo, what is your thought on that? I cannot offer this for intermediate risk.
Well, there are places where you can do that. So the thing here is like, because we have so many things available that you are able to really select what you're gonna do for your patients. Which means, like, as I was saying, if my only options that I have for my patients is Axipembro, I will use Axipembro for all of them. When I need to use iotyrosine kinase inhibitor, if I have only Cabo-Nivo, I will use Cabo-Nivo. But you have different combinations. And then you can to think a little bit more. You can be more selective, and then you say, I wouldn't use Axiavelo for intermediate because I can, but I would use it for favorable or for poor patients that require iotyrosine kinase inhibitor.
Thank you. So I think that's fair. So it's more of a statistical uh, thing than the clinical. The effects are clinically meaningful and we can safely use. Now coming on to the TKI of preference, Dr. Shantanu, your thoughts. If I use cabozantinib or lenvatinib, so it's
Sir,
it's a
my thought is preferred is lenvatinib or axitinib, depending tolerance. Axitinib, unless patient is hypertensive, uncontrolled hypertension or this case, axitinib is my preferred drug. Cabozantinib, in my opinion, is a good second line drug. So not first line drug in my practice. However, I have used cabozantinib if I'm using nivolumab for cost reason in first line.
okay, fair. So, Dr. Shantanu, if I can keep you on hold. So let's say for a patient, I gave nivolumab cabozantinib. Patient developed a grade 3 diarrhea. So how do you handle that patient?
Sir, I'm skeptical for all diarrheas with immune checkpoint inhibitors. I have seen colitis more commonly than what we see in our data sets or whatever trials report. So diarrhea, for any diarrhea that is grade 3, one dose reduction for cabozantinib, not more than one, low threshold for colonoscopy and biopsy in my practice. I have seen colitis more commonly than, as I said.
Right. So, Professor Guillermo, grade 3 diarrhea, 3 days over after stopping cabozantinib, it is not subsiding. So, how do you handle this? Cabo
You
can
mean
be
with,
there in your body for quite long because of a long half-life.
sorry,
So,
so the patient is taking cabozantinib.
yeah, nivolumab plus cabozantinib.
Okay, so what I mean, if you have diarrhea with cabozantinib, you stop treatment. Obviously, you stop the cabozantinib. But for that patients, if you have a grade 3 diarrhea, I would start steroids right away. Because even if you stop cabozantinib, the patients will continue having the diarrhea because of the cabo, but you will not know. That's why I would start right away the steroids with a grade 3 diarrhea, because it could be related with the nivo. If you are having Axiavelu, by contrary, what I mean, it depends how grade 3. But if it's in the limit, I would stop the axitinib. I will give some fluids, and I will reevaluate the patients in 24 hours. If it's improving, I will continue, yes, with that. But if it's not improving, I will start high dose steroids as well.
Great. So I think low threshold for starting steroids. That's the key. What you said.
Yeah.
Right. So, Dr. Dubey, I'm back to you again. So, Dr. Dubey, this is the curves I think Professor was showing. Consistent separation of curves over a longer follow-up versus keynote 426, where the curves, come close together and the significance is lost on longer follow-up. So, how do you look at this efficacy of Avaxi versus Pemroaxi?
So it's very well clear that the curves are not converging in Javelin Renal 101 with the Avelumab plus Axitinib. So surely it gives me confidence to use that regimen.
Right. So, Professor, any biological rationale for this consistent separation in Avaxi arm? Again, the similar side effect thing.
I honestly, at this point, so the only options. Probably there are different options. One of them is the rationale that avelumab is providing that extra effect through the NK effect
In case of,
and the ADCC. So are affecting also the dendritic cells, so the immune system is better reestablished. That would be the ideally a more biological rationale. But the other one is like, I guess, because you can maintain the lower rate of discontinuations may provide that you may maintain the treatment for a longer period of time. Said that could be many other reasons that we are not controlling, because the longer is the
Right.
follow-up, there are more bias that you are not controlling. So it's too much to try to make an argument here.
Right. Fair. So it may be different drug, it may be difference in post-treatment side effects. So multiple factors are contributing for this consistent separation. Fair. Right, Dr. Alok, I'm back to you. So, we have been using IO more and more often nowadays. We have got Chinese IOs, we have got biosimilar IOs, we have got low dose IOs, so many in India, So, the more you use IO, you realize it is not an easier drug to handle, and you just heard that professor saying I'll start on steroids liberally. So, how difficult is to handle these IO toxicities and steroids and their side effects, Dr. Alok?
Generally, I prefer keeping steroids to as low as possible, maybe zero. But whenever there are IO-related toxicities and we do need to use steroids, we do use them. Overall, I would say around 5% of patients end up receiving steroids because of IO-related toxicity. 90% they do not. So, yeah, so that is the average figure.
Right. Remember, once you start on steroids, you can't, like, let's say pneumonitis, you cannot taper and stop them in a month or so. You need to go on and on for at least 8 weeks or even 12 weeks. Otherwise, the pneumonitis is going to recur. So steroid is a real challenge, and the less you use, the better it is, even in terms of the biology of disease is concerned. So, Professor, how important it is to use as much less steroid as possible in any immunotherapy molecule? Professor, yeah.
Yeah, no, I was just thinking. So the use of steroids. So I guess there are a couple of things that are relevant. So first of all, you don't want to use steroids at least with. So there are kind of some scenarios when the data are quite solid about, or at least against, using steroids, high dose steroids. That's the typical situations with brain mets and melanoma. For those patients, you don't want to use ipi/nivo if they are having high dose steroids. Still, sometimes you need to do it, and the patient still do well. So the idea about using high dose steroids and the patient not doing well in terms of that it's affecting the immunotherapy, it's something relative. So it's not as solid as we would like to have, like high dose steroids and then immunotherapy is not working. Indeed, there are many patients doing quite bad, requiring high dose steroids and doing well. However, the main issue, in my opinion, or there are multiple factors again when you are using high dose steroids. So first of all, is that when you're using a high dose steroids, you need to stop. Usually both drugs. It's not about stopping the the tyrosine kinase inhibitor and the IO. It's about stopping both. Because if you have a one patient with 1 milligram kilo and is patient admitted, you may stop the treatment for 1, 2, 5, 6 weeks. And the issue is that when you are 6 weeks without treatment, you may have progressive disease. So that's one of the first factor. The second one is that high dose of steroids, it's associated with multiple adverse events. And thus the patient may have an extra complications due to the high dose steroids. That's the second one. And obviously, the high dose steroids may eventually affect the treatment. Obviously, that's the last one. But in my opinion, the first two ones is like you need to stop both drugs. And the second one, steroids is not a free drug in terms of adverse events either.
Excellent. So once there is IRAE, you have to stop both the TK and the immunotherapy. You can't just stop IO and carry on TKI. That's important. Right now, I think we saw the data on patients of sarcomatoid, elderly patients on dialysis. So many aspects we saw, and this is the impressive response rates we saw in the sarcomatoid component, and this is patients with dialysis, and this is how safe they are in acute kidney injury. And then this is the amount of pneumonitis that these immunotherapy molecules cause. So, let me ask Dr. Dubey. Dr. Dubey, your thoughts on using immunotherapy TKI combination in these specific scenarios of sarcomatoid patients with acute kidney injury or having a higher creatinine and with a background of a bad lung. So how do you look at this data?
Well, so that's something that is giving us more options for our patients. One of the issues when you have patients in your clinical practice is like you have to face with patients with multiple comorbidities that were not included in clinical trials. And when you're seeing all those kind of patients treated in different studies or sub-analysis or case reports, looking at the data that is quite safety and the efficacy remains as something valuable, you are at least more relaxed when we want to use these drugs in these patients. So obviously you would like to see a perfect patient with ECO 0, but the reality is like we see plenty of patients with multiple complications, with pulmonary issues, with dialysis,
Right.
with bad kidney function. And what we've seen is like for combinations, for example, with Axiavelo is still working pretty well in those patients. So we wouldn't have to be afraid of that.
Thank you, sir. So, Dr. Dubey, your concluding thoughts, and then we can sort of call it. Yeah,
Already, Professor has so nicely and concisely has concluded it. But I wanted to ask Professor that there's data that if steroids are used for immune-related adverse events, they actually do not impact survival. We have real-world studies Even that 1 to 2 milligram per kg of body weight methylpred or 0.5 to 1 milligram per kg of prednisolone, they do not impact, and sometimes it is surrogate of immune activation. So sometimes it is surrogate of good response. So only at the baseline, if we are using before starting ICIs, if we are using steroid for more than 10 milligram per day, only that is detrimental. I hope if professor can clear my doubts. Thank you.
Please go ahead,
Yes,
sir.
absolutely. Yeah, absolutely. As I was saying that we don't have data specifically to say that high dose steroids are gonna impact in that. But what I was saying is like in the other side is like sometimes when you are using high dose steroids, when you are using, because there are different things here. So one is when you're using just immunotherapy in general, like it's like you compare immunotherapy by itself and you need to stop, those patients having immune-related adverse event usually have better survival in general in other solid tumors. But
Right.
specifically, when I'm saying in kidney cancer, so you have a patient with, that's something clear. If you have a patient with poor prognosis, renal cell carcinoma, you treat that patient with whatever you're treating. You need to stop the treatment and you need to give that patient high dose steroids and to stop treatment with the tyrosine kinase inhibitor and immunotherapy. That patient is going to do bad in general, not always, but in general.
I think great thoughts are, I think, very important thing. I mean, the less steroid you can use, the greater it is. And if there is a IRAE, that is a patient who's going to live longer. This data also we have. In all means, we would love to avoid steroids. So that is what we would want to do. So, well, these are the concluding slides for today. I think we had an elaborate discussion, a lovely talk by Professor, and then real world by Dr. Alok. And probably these are the concluding points for today. Favorable risk TKI alone probably is not the way. You can have an IO TKI because the hazards are very impressive based on the subgroup analysis of randomized trial and the real world data. Avelumab axitinib is the favorable combination for the favorable risk, and then it is equally effective in the poor risk category we can use. Probably the statistical significance wasn't met because of trial design. It has a clinically meaningful benefit in all risks of RCC. And then it is very important to have a combination that has least toxicity in terms of discontinuation, steroid use, pulmonary safety, using in sarcomatoid patients and also with ESRD patients. Avaxi has shown impressive results. So, in the host of so many combinations of IO, TKI, Avaxi has its unique place, being effective in all the risk groups, especially in the favorable risk group. So, with this, I would thank all the panelists and Professor Guillermo for sharing his hands-on experience and the biologic rationale for using this regimen. So thanks again, sir, and thanks all of you for sharing your wonderful thoughts. Thank you. Over to you, Julie.
Thank you
Yeah,
so
Julie? Yeah.
much. Thank you so much for a great discussion. Super interesting. If Dr. Advani sir is around, I would like to invite
Yes, yeah,
him. Yeah.
yeah.
Yes, sir. Over to
Thank you,
you.
thank you. Thank you very much. I think it was very clear listening to the professor and all the eminent panelists that how clearly they have sort of shown that avelumab in combination with the TKI is going to play a very important role in the management of the RCC. I think this is one data which clearly shows that it's not only just effective, but it's least toxic, and that it can be used across all the risk factors. And I think that makes it really better. And we also understood that how effective it is, even in the presence of the dialysis, even in the presence of the steroids use. So I think all these points which were discussed in depth have really cleared our doubts. And I'm sure we will be able to use this combination more and more in our patient. With this, I would like to thank the professor as well as all the members, panel members who have given us an extremely important message. Thank you very much.
Thank you so much, Advani sir, for the final concluding remarks. And I would like to thank all our faculty members and everyone in the audience who has been listening to us. So I hope we all take something meaningful and some meaningful learnings from the discussions today and wish you all a great weekend ahead. Thank you.